Myself, Dr. Tapas, I would be discussing about again the part that everybody wants to score 10 out of 10, that is the radiology. Okay, so I would be a little bit crisp and also giving you clues rather than extensively discussing in detail. So, the topic asked in every exit exam from the radiology comes from the chest x-ray, abdominal x-ray, ultrasound, chest, abdomen, that is the POCUS, echo, CT scan. CT scan can involve brain, chest, and abdomen. MRI brain, though MRI brain will not be that frequently asked, but yes, sometimes the specific exact like diagnostic thing would be also asked from the MRI. Doppler scan, that is the DBT, and TCD. These are the frequently asked radiology part questions in your practical. Now, I would not be taking much time because X-ray, chest X-rays, ultrasound, this is very self-explanatory. So I would be just showing you how you should be answering in your exam rather than the theory part in detail. From the chest X-ray, the most frequent domains that normally get asked is ARDS, consolidation, collapse, cavity, pneumothorax, pleural effusion, hydropneumothorax, foreign body, hiatus hernia, abnormal position of lines. Now, how to read chest X-ray? This is a very simple, I would say, a straightforward way of reading the chest X-ray. First one, normally, like you should be looking at the name, date, the view, PA, AP, lateral. You all know. I'm just trying to summarize it. Right and left sternoclavicular joint equidistant from the midline. So that would be the chest X-ray centered, the exposure and the inspiration. Now, normally, if you want to get a perfectly correct exposure, you would barely be able to see the intervertebral disc through the chest X-ray, through the heart, I would say. So you would not be able to see the intervertebral disc through the heart. Now, over penetrated, you will see the intervertebral disc very clearly. Like in this, you can see intervertebral disc, intervertebral disc, intervertebral disc. This is over penetrated. Now, under penetrated, what is happening here? Intervertebral disc are not seen in the film. Now, you have to see in between. So that would be the correct exposure. Now, in the inspiration, 6 anterior ribs visible, 10 posterior ribs visible. That should be the perfect way of like having a correct anatomical as well as the exposure. Now expiration also, you have to be also a little bit like see exactly you are getting the chest x-ray. Now I would be straightforward going into the questions. 48-year male, surgery, hipple surgery done, 2 hours later in the ICU, patient is having decrease in SpO2. I want the answers. Okay. Please be quick so that we can like finish maximum. What is happening here? Post Whipple, 2 hours later in the ICU, patient is having decrease in the oxygen saturation. Yes, it is right endobronchial intubation, left lung collapse. And normally, like why you are saying that the left lung collapse and right endobronchial intubation? Normally, the maximum allowed distance is 2 centimeter above the carina, the tip of the endotracheal tube. Now, always check the ET tube position first, and the ET tube tip should be 2 to 2.5 centimeter above the carina in the neutral neck position. Neutral neck position, you all understand. What do I like mean by this? Now, too deep, right mainstem intubation, unilateral ventilation, collapse of the opposite lung. That has happened in this patient. Quick correction, life saving in ICU and examinations. Don't always just tell about the problem. In the examination, they also want the corrective measures. Now, follow a fixed stepwise pattern. Examiners always love the structure. Airway, breathing. Breathing is the lung field. Circulation is the mediastinum. Devices or lines, then bones, then soft tissue. Never jump around the field. Right. So always start with the ABCD. Airway, ET tube is entering. Breathing, lung field. Circulation, mediastinum. D for devices and lines in the chest X-ray. Bones and soft tissue. Compare both lung fields for symmetry, whether there is volume loss, opacity, shift. Now in this case, very clearly left lung collapse due to right mainstem intubation. Mediastinal shift towards the collapse side, which is the classic. So you all have like bits and pieces answered, but nobody has actually answered in complete one package. So you will not be getting 100% marks. Now, identify all tubes and lines whenever you see any X-ray, though I was specifically expecting the correct answer, but in the examination, the examiner sometimes want that you should be identifying all tubes and lines. Now, the checklist here is the ET tube, ANG or OG tube, central line, where is the tip, chest drains, pacing wires, ECG leads. Now, the examiner would be always trying to have a misplaced line, which is a common exam trap. Now assess the diaphragm and costophrenic angles also. Elevated hemidiaphragm suggests collapse or atelectasis, because what is happening now, the lung is collapsed, so somehow the diaphragm is also tented up. Blunting suggests effusion. Now here in this patient, what happened? Left hemidiaphragm elevation that supports your left lung collapse. So I am trying to give you so many answers. It's not only left right endobronchial intubation, it's not complete white out left lung. Rather, it is a summation of all the answers that I have already till now shown you. Always link the radiograph to the clinical deterioration. Examiners want clinical reasoning, not description alone. Now, example in this, I am trying to share with you the correct way of answering if the examiner gives you clue and also expects a better detailed answer. Hypoxia, new oxygen desaturation plus postoperative status. You should be checking the ET2 position where I am getting the right main bronchus intubation. Immediate correction has been done by taking or withdrawing the tube 2 to 2.5 centimeter. That improves the SpO2. Now, in every ICU X-ray, first identify life-threatening reversible findings. Life-threatening like tube misplacement, pneumothorax, collapse, and then describe systematically. Don't start with I can see the patient's skull, I can see the ET tube entering through the oral cavity or through the nasal cavity. Don't jump around the chest X-ray. Rather, immediately explain or identify the life-threatening reversible finding. Reversible finding. This is the word the examiner wants, because if you do it immediately, the patient's life gets saved. Otherwise, if you do so many other things without mentioning that the ET tube is actually malpositioned and entering into the right mainstem bronchus, then the examiner would be really pissed off, because we want the trainees or the attending should be smart enough to actually save the patient, not harm further. Now the second one, smartest finger smartly, you have to answer it. ICD in situ for right hydropneumothorax. Is there any problem? Now I am giving you the clue itself. ICD in situ for right pneumothorax. Oh, it is left pneumothorax. Yeah, sorry, it is left. Sorry. Is there any problem, or I am just sharing with you the answer? Okay. Can you explain in little bit detailed way? Trap lung. The examiner would be trapping everyone. So the lungs are not the only thing that would be trapped. We also will be trapped. And we all will be malpositioned there itself, because otherwise we will not be getting the correct answers. So just on a lighter note, I am just sharing ICD is not functioning properly inside the thorax, but not in the pleural space. So always expect that the examiner would not be giving you the correct no, I would say the X-ray with the ICD in situ. Rather, they would also expect that you would be answering some of the complications that has happened due to the ICD. Now, always identify the ICD path. Trace the ICD from the skin, soft tissue, thoracic cavity. Its final tip. Okay, so it should be the way: skin, soft tissue, thoracic cavity, and the tip. And the most important step in Viva, correct normally placed ICD tip location. Now for pneumothorax, it should be apical, anterior, superior. For fluid, posterior basal. You all know why I am talking about fluid. The tip has to be posterior and basal. Pneumothorax, it should be apical, anterior, superior. Now, tip should clearly lie in the pleural space, not too far, too deep, or too superficial. So, not in the lung parenchyma or the fissure. Clear? Now, recognizing malposition in this X-ray, the previous X-ray that I have shown, tube is within the thorax, but sitting inside the lung fissure, intraparenchymal plane, not in the pleural cavity. Now, hence, we can conclude that this ICD is not functioning properly, and this is one of the commonest exam traps. And somebody has also answered correctly, trapped lung. Okay. Now, radiology clues ICD is not functioning from the chest X-ray. Now expected pneumothorax re-expansion. Yes, that was clearly seen in the X-ray. No fluid drainage. Maybe the examiner would give you a clue. Tube tracks along fissure. Tube tracks along fissure. Tube doesn't align with the chest wall curvature, and tip appears rounded or blunt, not in the free pleural space. So self-explanatory, I'm not again reading it. Clinical implication, malpositioned ICD will be having persistent hydropneumothorax. Somebody has mentioned hydropneumothorax or hydrothorax, but you have to use the word persistent hydropneumothorax. Now, you have already put the ICD in a case of hydropneumothorax, but this lung is not expanding. So that means there is persistence of hydropneumothorax, persistent dyspnea and hypoxia if the patient's clinical condition has been given, and also there is high risk of parenchymal injury, bleeding, ineffective drainage. Now, what the examiner expect you to say, the gold standard in the examination, if I am the trainee, what I would be answering that this ICD is intraparenchymal or fissural, not in the pleural space. As a result, I would conclude that this ICD is non-functioning and it must be removed and reinserted with correct imaging guidance, because already you have created the the track and you have put it in the wrong place or wrong site. So maybe I need the imaging guidance to put it again, reinsert it again so that it would start functioning. So always remember that malposition is very common in emergency insertion, especially in the mid axillary line with shallow angle. Now, take home message for this X-ray, an ICD inside the thorax doesn't guarantee it in the pleural space. So always trace the tube as I have given you the clue and confirm the tip location. Now, next question. 88-year-old man, multi-system failure, septic shock, and NG tube was placed. You have ordered one chest X-ray and this X-ray has come like this. Straightforward answers, please. Let's be quick. Any significant finding, and what would be your next step? Everything okay? Should I start giving oral medications through this NG tube, or the NG feeding also? Malposition NG tube, remove, reinsert. Right bronchus, then left. Malposition coiled. Yeah, okay. So answers are getting little bit better framed now, but yes, still you need to improve upon your answers because you all know it. I am not saying that this is a very uncommon X-ray. Everybody has seen this X-ray, but how to answer it in the examination, that is the trick. And in this webinar or all of our courses, we try to give you a structured approach. You have seen also the previous speakers. They have emphasized on how you are actually answering. The same answer Mr. X has given, he is scoring 3 out of 5. Similar action answered by Mr. Y and he is getting 5 out of 5. So that is the art of answering the exam. Now NG tube coiled and in left bronchi. So that you have already answered, but it's not the end of the answer. I would now go into the detailed analysis of the answer or the problem. Always trace the tube from nose, chest and abdomen. A structured approach is essential. Look for midline descent. It has to be in the midline. Passage behind the heart shadow. The heart shadow and the NG tube would be passing behind the heart shadow, crossing the diaphragm. Tip position should be in the stomach. Now in this film, the previous film, tube deviates into the airway, not midline, very clearly seen. Now red flags for the airway placement, because now the tube is not in the the stomach or esophagus, rather it has entered into the airway. So somehow you have to follow the tracheal line, the courses along the bronchial tree. You can see the left main bronchus has been infiltrated. No gastric bubble or subdiaphragmatic course. Everybody can recognize that. And tube appears too rigid or straight towards lung field. You can see. I'm just showing you. Yeah, it is very straight or too rigid to enter into the left main bronchus. Now, coiling or malposition. If the NG tube is coiled in the chest, it is never in the stomach. Dictum is that if it is in the chest, it is never in the stomach. This is a critical mistake. Coiling often means tube entered airway, hit bronchus, or folded back on itself. Now, life-threatening complications. Sometimes the examiner love that you have put the an NG tube into the bronchus or in the airway. Now, what would be the complications? Complications can be if you start feeding without confirming or reconfirming chemical pneumonitis from feeds, aspiration, iatrogenic lung injury, pneumothorax, intrabronchial perforation. And this is the reason all ICU NG tubes must be confirmed before feeding. No, all this 20 ml syringe putting air into this NG tube. No, this is like something very crude way of confirming NG tube. Now, immediate management, clear, simple, exam friendly. If you have already put it, now what will be your next step? The examiner sometimes likes to ask you that yes, the blunder has been done by you. Now stop all use immediately. Remove the tube. Reinsert under direct visualization like laryngoscope or video laryngoscope. Confirm position. How will you confirm? By doing one chest x-ray, or if the tube is already there but you want to again confirm without taking it out. Sometimes the examiner would also ask you that look, the doctor, this is no one x-ray you have put after so many attempts. Patient is coagulopathic. You don't want to take the tube out because you are slightly confused. You know that yes, this is in the correct place, but you don't want to start feeding without reconfirming. What will you do? You can just aspirate the gastric aspirate, and the pH you have to check. Okay, pH has to be around less than 4.5 to 5, like that has to be acidic. So something that you can do, and you can also get one clue that yes, without taking the tube out and putting the tube again, another new tube, you can just do like this. Okay, now never rely on the auscultation alone. What we do normally, please don't do all these things in the examination. Examiner would be failing you. If aspiration occurred, supportive management plus bronchoscopy. Now examiner's expected final statement, always you should be getting credit that this is an inadvertent tracheobronchial placement of NG tube with coiling in the left main bronchus, and we must not be starting the feeding, and nasogastric tube should be reinserted with proper confirmation before use. So maybe if somebody immediately reframing the statement that you have given, but in 3 lines, first one is the problem, what would be the complication, and what would be the next step? Are you getting it what I'm trying to say? So this is something like you are framing it well to get impression from the examiner, right? Okay, so NG tube doesn't cross the diaphragm. That is our old school teaching. Doesn't cross the diaphragm. Assume it is in the lung until proven otherwise. Clear? Now, what is happening here? Already discussed by our previous speaker. All the is there anything, any device, any lines you can see? So 70-year-old known case of advanced glioblastoma multiformis now admitted with shortness of breath. Comment on the invasive line. So ET tube in proper position, VP shunt, catheter in situ. Okay, perfect. So you can see that intubated patient with the VP shunt in place, well placed ET. Excellent. Now Jaydeep, you have cracked it. So always try to have a very well framed sentence rather than very blunt answers. ET tube in place, right pneumothorax, something like no, the examiner would be not like no wish to uh, hear all those like no very straightforward answers. They want some like no well framed answers in a very polite way. And as you are a very experienced doctor who is about to clear your exam and becoming the consultant in the ICU, so that should be the way you should be moving away. Now, cardiogenic shock after drug overdose, intubated, chest X-ray in ICU. You have done. This is the X-ray. What are the things you can see in this X-ray? IABP tip is in the correct place or not? That you have to say. IABP tip. You can see IABP tip, but you have to complete the sentence. That's why I'm trying to again and again emphasize that your answer should be not only identifying. Somebody will say, and where is crossing from right to left direction? What do you mean by that? Is it right? That would be very non-specific. Okay. So malpositioned IBP, you can say well-positioned ET tube intubated with silicone pad with transvenous spacing with ECG leads and wires. But yes, you are right. But malpositioned IBP tip too high. Yes. Transcutaneous spacer ET2 proper position. Now you know how to answer because the examiner would not be giving you only one line or device in the X-rays like no, they would be keeping. So they would have multiple things. Now this has been discussed in detail by Dr. Sanand. So I'm not going into detail. Now here the tip is to up and these are something very important points, but from the X-ray point of view, IABP radio opaque marker should lie at the level of carina or the second or third intercostal space corresponding to 2 centimeter distal to the left subclavian artery origin. Now here tip is 2I, that is above the carina, so malposition. Clear? Now, why high IBP is dangerous? Examiners expect you to mention the complications, not that the high IBP tip will be dangerous. No. Why? Occlusion of the left subclavian artery leading to arm ischemia. That can be also occluding the vertebral artery that can lead to posterior circulation stroke, suboptimal diastolic augmentation, aortic wall injury or dissection. That is rare but important. Now, what is the correct radiographic position of IBP? You must say this clearly, tip at the level of carina or 2 to 3 centimeter below left subclavian artery, balloon body extending down to above the renal artery, above the renal artery. Now that should be the scoring line. Now, always systematically review any X-ray you are getting, all devices and the film. Now in this X-ray, ET tube is in the correct position, 2 to 3 centimeter above carina, transcutaneous spacing pads, NG tube in place. Now, examiners like when you comment on all lines and tubes. I have already told you, not just the IABP. Now, what immediate management is required? Always told you, it is not the problem. The examiner expect you to answer the solution, the management part. Now, we'll notify the cardiology or bedside clinician, withdraw the IBP by 2 to 3 centimeter under wave for monitoring, reconfirm by chest X-ray, and ensure the improved augmentation. Now, definitely with the tip too high, there would be suboptimal diastolic augmentation. So, when you are withdrawing the IBP by 2 to 3 centimeter, that would definitely ensure improved augmentation. Now, examiner's goal statement, honor students. I know in this 100, how many people are here? 105 people are there. So, national topper is in this group. I am making you all happy. So, whoever is staying till 10 p.m. from 6 p.m., 3 hours 42 minutes, still waiting for the like clues and some of the best like I would say framed answers to know. So definitely you all deserve to be the toppers. But yes, if we will see, definitely the national toppers are in this group. So your answer to get the gold medal should be this is a high riding IBP tip above the carina. Now the balloon will inflate across the left subclavian artery, reducing efficacy, risking limb and cerebral ischemia. It must be repositioned immediately, doctor. So if you are the attending consultant, if you are answering me like this and I am the chief, so I should be impressed. Definitely. And that also holds true for you to get the gold medal. Okay. Now, the take home message here, every ICU X-ray with IBP, check the tip position at the carina level. One quick look can prevent stroke or limb ischemia. That are the two deadliest things that I am completely like, right now having my eyes quite awake open. Okay. 16-year-old male, severe burn, 40% blood, body surface area, burn, developed respiratory distress, and second day of admission to the ICU. What is happening here? Can you read the X-ray? Only significant finding. I'm not again going into detail because we don't have time. So I would be now expecting only the significant finding. Okay, I'm making it clear. But yes, where is the IBP tip? So you want to see the IBP tip, Dr. Hitesh? Okay. No problem. I would be showing you the IBP tip. This is the IBP tip. Okay. Should be the answer here. Can you read the problem here? The X-ray? Anyone? What has happened? 40% burn, respiratory distress on second day of admission, 16-year-old male. Bilateral multifocal airspace opacification, mainly perihilar and lower zones, ARDS. Clear? I'm just keeping with the exact significant finding. 79-year-old man, 48 R, history of cough, low grade fever, right sided pleuritic chest pain. What is the X ray finding? What is happening here? Yes, right upper lobe pneumonia. Okay, perfect. So airspace shadowing and air bronchogram in the right upper lobe, community acquired lobar pneumonia. So community acquired lobar pneumonia. You can just like the better frame your answers. The difference between collapse and consolidation. Collapse, there would be volume loss, ipsilateral shift, no air bronchogram, apex is at the hilum. But consolidation, it is normal or increased volume, no shift. If present contralateral, air bronchogram would be there and it is not centered at the hilum. Consolidation will not be centering at the hilum, but collapse somehow will be centering at the hilum. What is happening here? Marked diffuse colonic dilatation. What is the clinical syndrome? You all know. Yes, ileus. I'm talking about a syndrome. Ogilvie syndrome, and some of the important things I'm not going into detail, but yes, massive diffuse colonic dilatation involves cecum ascending transverse colon, often up to 10 to 12 centimeter, no mechanical obstruction, no transition point, small bowel, usually normal caliber. That would be helping to differentiate obstruction. Classical exam description would be diffuse gaseous distension of the colon up to the rectum with no air fluid level and no mechanical blockage. So it is actually acute colonic pseudo obstruction. If somebody doesn't know Ogilvie syndrome, they can also answer acute colonic pseudo obstruction. Now this sentence scores full marks. Now important risk factors, exam loves this list: critically ill ICU patient, sepsis, shock, major surgery, trauma, electrolyte abnormality, mostly in the form of hypokalemia, hypomagnesemia, hypocalcemia, opioids, anticholinergic use, neurologic disorders, prolonged immobility. Now, why it is dangerous? There would be risk of cecal ischemia and perforation when your cecal diameter is more than 12 centimeter with duration more than 6 days. Mortality dramatically increases after perforation up to 40%. So cecal diameter more than 12 centimeter and when the duration is more than 6 days, so there is high risk of cecal ischemia and perforation. Now treatment approach, I have already we have discussed in our regular classes and you also all know. First one would be conservative. Never ever immediately start with the radical surgeries. Stop opioids or offending drugs. Correct electrolytes. NG tube decompression. Rectal tube. Bowel reset. Mobilization. Now the second one would be pharmacological. IV neostigmine. The examiner loves this drug. 2 milligram slow push. 90% success. Monitor for bradycardia. You should be keeping atropine ready. Now, the step 3 would be invasive in the form of colonoscopic decompression, surgical management only perforation or peritonitis. Examiner expected red flags. Always mention no air in the rectum doesn't exclude Ogilvie. Beware of the pseudo diarrhea. Like it's not always that there would be constipation. Just try to have this thing in your mind. It would be pseudo diarrhea. Never confuse with mechanical large bowel obstruction. Look for hostrations, uniform dilatation, high cecal diameter. That means impending perforation. Always have this take home message: massive colonic dilatation without a mechanical transition point in a sick patient, Ogilvie syndrome. Treat early to prevent cecal perforation. Now next one would be detailed ultrasound and echo. Definitely it is not possible to explain so many ultrasound and echo, but yes, these are the more or less the domains that can be asked from this POCUS: pneumothorax, pleural effusion, pericardial effusion or tamponade, pulmonary embolism, RARB dilatation, pulmonary edema, IVC diameter and collapsibility, poor LBEF, that is systolic dysfunction, cardiogenic shock, mitral stenosis, mitral regurgitation, diastolic dysfunction, diaphragmatic dysfunction, sometimes also diaphragmatic dysfunction. Also in the weaning difficulty they would be sharing some or other, like the screenshots. Thrombus in the LV. Now some of the complications of the myocardial infarctions like VST, AMR, and again Takotsubo cardiomyopathy. Normally the examiner likes to put subarachnoid hemorrhage at the clinical vignette, and then following that they would be showing you that this patient has developed cardiogenic shock. And now when you do the echo, you are getting this typical, like the ultrasound or POCUS finding. Now that would be revealing that yes, you are dealing with Takotsubo cardiomyopathy. Now I'm just sharing with you few of the important ultrasound and echo clips. 47-year-old man had a road traffic accident and injury to the chest wall. He is complaining of chest pain, and you wonder whether there is a pneumothorax. What is happening here? Okay, so there is pneumothorax. Definitely, a road traffic accident, injury to the chest wall, pneumothorax with loss of lung sliding. I know everybody knows in this group what do you mean by, absence of lung sliding, and what are the typical ultrasound findings of the pneumothorax. So I'm not going into detail. Yes, excellent, Jaideep. So you have to frame your answers in better way. Now, pneumothorax abolished lung sliding, stratosphere sign on the M mode, the A line sign, one B line. Remember, one B line is enough for ruling out the diagnosis confidently where the probe is applied. Now, lung point, most specific, transition point between the mobile and the immobile lung, that is the specific for pneumothorax. Now, if you see, so this is like the normal lung slide, and here the abnormal lung slide. So, lung point is here. Okay, you can see. So M mode, you can see the lung point sign here, lung point sign appear at the precise line where the seashore sign is changing or switching to the stratosphere sign or barcode sign. So here you can see the seashore, and here you can see the barcode. Okay, it is very specific sign for the pneumothorax. 50-year-old smoker with fever 1 month, shortness of breath last 7 days, left-sided chest pain for 4 days. So it is gross pleural effusion with underlying lung collapse. Don't ever immediately jump to the answer. Rather frame it well. Involve 2 3 other problems also simultaneously rather than only particularly pleural effusion. You want to insert right IJB under ultrasound guidance, and this is something what you are getting. What is happening? Right IJB thrombus. Okay. Are you sure you are getting it right sided or left sided? Is there anything mentioned? Yeah, in the question itself. But yes, you have to always see that whether it is right or left, rather you should be answering it is IJB thrombus. Okay, perfect. IJB contains heterogeneous and echogenic thrombus. 54-year-old male presenting with collapse while moving couch. The patient is on antibiotic for recent pneumonia, altered mental status in the emergency department. What is happening? Definitely will get this type of infective endocarditis. It is actually parasternal long axis with large right heart and septum bowing into the left ventricle. Diagnosis is massive pulmonary embolism. Yes, perfect. So what are you seeing here? Right ventricle is actually dilated compared to the left ventricle in the plaques view. So right ventricular dilatation, septum bowed into the left ventricle, D-shaped LV in the short axis, septal flattening in the parasternal long axis. That would be concluding as we are dealing with pressure overload. Now small underfilled LV cavity, reduced preload due to RV obstruction. Clear? Possible right ventricle free wall hypokinesis with apical sparing. You all know it, McConnell sign, supportive, no, but that is not the specific. Dilated RA and RB, acute corpulmonal picture. Now, clinical integration, how you are answering in the examination. It's not like no that right ventricle is dilated, left ventricle is not like no that much dilated. These are like no very bits and pieces answers. The examiner would not be impressed when you are like appearing the DrNB final exam or DM final exam. So it is always you should be writing or you should be answering shock plus syncope or collapse plus recent immobility or infection. Think of massive like the pulmonary embolism. Echo shows acute right ventricular pressure overload, almost pathognomic for the pulmonary embolism in the right clinical setting, and use this phrase. Echo demonstrates acute right ventricular failure physiology with septal bowing compatible with massive P. Okay. Now, rapid differential, it's not always that right ventricular dilatation would be resulting in or the diagnosis would be pulmonary embolism. But yes, the first one should be massive pulmonary embolism, that is acute rise in the right ventricle after load, acute RV infarction, severe pulmonary hypertension, whether acute or chronic, tension pneumothorax or severe asthma because of dynamic RV compression, cardiac tamponade, RA-RV diastolic collapse rather than dilatation. So also RV dilatation, you will be not getting typical like no the dilatation, but there would be diastolic collapse. It would be collapse. You can confuse whether it is dilatation or diastolic collapse. Now, high yield pulmonary embolism echo finding, you will definitely get this in your exam. So always remember not only the specific one or two things that can be seen in your like echo clip. Rather, you should be remembering all the things that you should be answering in your OSCE. Right ventricular to left ventricular ratio more than one. Interventricular septal flattening. That means your systolic is equal to the pressure overload. PR jet velocity increase as a result. What is happening? RVSP is elevated, reduced TAPSE less than 17 millimeter, RV free wall hypokinesis, that is McConnell sign, IBC dilated non-collapsible, small LV, that is empty LV. This way. Clear? Now, what are the management triggers? Again, I have already told the examiners don't want you to be like no only identifying because they also want you to treat the patient. Now, you are the examinee, you are the like no the doctor on duty. Now, you are getting this type of patient. You have done the POCUS. You are informing the consultant. Now, the consultant would be senior consultant would be expecting as you are the consultant recently joined. Now, you should be knowing what will be your management triggers. Now, here hemodynamic instability plus echo is now showing RV strain. So I would be definitely thinking to start the thrombolysis immediately. Now I have to now consider systemic thrombolysis, which is the first line in the massive pulmonary embolism. You can also think about catheter directed thrombolysis when your systemic anticoagulation or thrombolysis is having high risk, and ECMO if the patient is not maintaining like the hemodynamics. So maybe I can put the patient on ECMO as bridge therapy and embolectomy in extreme conditions. Avoid aggressive fluids because this patient will not support fluids because that would be worsening the RV dilatation. I can start with vasopressors in the form of norepinephrine plus minus vasopressin, and also add one like inotrope if there is low cardiac output in the form of dobutamine, and anticoagulation as soon as possible. So this should be the correct way of managing this type of patient. It's not important to like only diagnose. Now one line exam conclusion, perfect closing statement. If in the examination, if somebody is answering in this way, this is plaques view. parasternal long axis view showing acute right ventricular dilatation with septal bowing causing LV underfilling consistent with acute right ventricular pressure overload. In the typical clinical context, I would be concluding that this patient is most likely a massive pulmonary embolism. Most likely, these words are like no the buzzwords. The examiner would love to like no hear these words. And if you are answering so confidently like this, and along with the management trigger, why you are like no thinking to going for thrombolysis, you will get, I would say, like no platinum medal rather than only gold medal. Okay. Now, post CABG day 2, patient has developed cardiac arrest, and this is the typical POCUS. Apical four chamber view, massive pericardial effusion, cardiac tamponade. You all know, I'm just now showing post op day 1 oliguria. You want to check the volume status. What is happening here? Anyone? You did it. Now what is happening? Longitudinal view of the IVC deep to the liver. The IVC is flat with complete collapse on inspiration. Very little filling seen only during atrial systole on expiration. Now this is one of the very favorite question and we all do it regularly. IVC assessment. Now you have to answer it well. I know everyone in this group have done the IVC assessment as well as the management as per the IVC assessment, but they have to answer it so that the examiner would be so confident that yes, this person has done minimum 200 times IVC assessment in his or her like training period. So it's a longitudinal IVC view below the liver. IVC is flat or slit like, complete collapse during inspiration, more than 70% collapsibility, very little filling seen only during atrial systole. That is indirectly evidence of the low RA pressure. Now what is the clinical interpretation? IBC less than 1.5 centimeter plus more than 70% collapse as in this POCUS finding. That means low right atrial pressure. RAP is 0 to 3 millimeter mercury, and this indicates intravascular depletion, not obstruction. So this is one of the etiology for your pre-renal AKI. There is no obstructive pathology, rather it is like no the fluid deficient and the patient has developed oliguria. So this strongly suggests pre-renal AKI, and this patient will be definitely having volume responsive oliguria. That means the oliguria will respond to if we will be giving fluid bolus and again reassess with the IVC assessment. Now exam winning lines, there is again another terminology, exam winning. This IVC pattern is consistent with low preload and high collapsibility, suggesting that this patient will likely respond to fluids, no signs of venous congestion. So if the examiner would be going little bit like no next step, that yes, this candidate is answering so well, I will be now going into the next way of like like assessing whether he or she knows about vexus. So you will be saying that this patient falls into the category of vexus grade 0. Okay, so something very impressive, and the examiner would definitely close the POCUS table there itself. Now, what are the management implications at this point of time? I would give a trial of guided fluid bolus. Don't ever jump into that. I will give 1 liter, 2 liter. 2 liter fluid. No, they have not given you the cardiac contractility status, the systolic dysfunction, diastolic dysfunction. They have not given you enough clue. So always answer it trial of guided fluid bolus or aliquots of fluid bolus, so that the examiner would know why you are using this aliquot guided fluid bolus. That means you know that if I will be going crossing little bit of this Frank Starling curve, I would be doing more harm to the patient. Now, what will be the other things that you can do simultaneously when you are guiding the fluid bolus? I would reassess the map, the urine output, the IVC, and the LV filling. I would avoid vasopressors without correcting preload. That means my preload has to be good only. Then only I will start the vasopressors if your BP is not maintaining. look for other causes of hypovolemia like bleeding, third spacing, inadequate intake. If I will not take care of all these things and only give fluids or like the vasopressor, it is going to be more harmful to the patient. Now, the examiner sometimes like to ask about what are the differential diagnosis for collapsing IVC. It is always that this patient needs fluid. No, hypovolemia would definitely the first differential diagnosis, whether it is due to bleeding, dehydration, post-operative third spacing. But yes, vasodilatation like in the form of sepsis, anesthetic effect, high inspiratory effort. If the patient is young and having severe pain, tachypnea, so definitely the IBC would be collapsing. And also diuretic. If you have given bolus dose of diuresis, definitely the patient would be now having IBC constricting. Okay. So and what are the red flags in the oliguric post-op patient? Tachycardia, cool extremity, hypotension, post-op bleed, occult abdominal collection, and you should be also simultaneously excluding the cardiogenic causes using plaques, parasternal long axis, short axis, and LVOT view. One line conclusion, if I want to score again 10 out of 10, a flat, completely collapsible IVC indicating low intravascular volume, and it would be definitely responding to the fluid and the oliguria should improve. Traumatic brain injury, intubated for low GCS. CT brain showed severe TBI with cerebral edema. Now unequal people with bradycardia. Immediately you have done ocular ultrasound and you are getting your the TCD to be 6.6 millimeter. So what do you mean by that? What is your diagnosis and what is your treatment? I know everybody knows this answer. Just like this is raised ICP, ONST diameter is more than 6 millimeter. So I need to control or reduce the ICP urgently by doing some of the tier 0, that is hyperventilation, head and elevation, hypotonic saline or mannitol. Now, clinical context, you have to remember severe traumatic brain injury with edema. Now new anisocoria plus bradycardia, that is Cushing response. Ocular ultrasound is ONST around 6.6 millimeter, that is raised ICP. Definitely the answer for handling the acute raised intracranial pressure, that would be leading to impending transtentorial herniation. Now in ONST more than 5 millimeter, that is cut off for ASEAN's 4.8 to 5.2. So that means definitely this patient is going into the raised intracranial pressure stage. But if it is more than 6 millimeter, strong predictor of dangerously high ICP, that is more than 20 to 25 millimeter mercury. Now what are the immediate life-saving treatment? Always mention in order. First 60-second herniation package. Remember herniation package. Optimize airway and oxygenation. Hyperventilate to keep PaCO2 30 to 35, which should be temporary only. Elevate head end to 30 to 45 degree. Keep neck in the midline. There should not be too tight, the central line or the ET tube tie. Stop sedatives that reduce blood pressure. Give analgesia and sedation so that this patient should not bite the tube or kinking of the tube should happen. Now the next one would be osmotherapy. You have to choose either of the two. 3% hypotonic saline, bolus 2 to 3 ml per kilogram, or mannitol 0.5 to 1 gram per kilogram only if patient is euvolemic and kidneys are working well. So hypotonic saline is preferred in hypotension or renal dysfunction. Now, next one would be urgent neurosurgical measures. Call the neurosurgeon immediately. Prepare for external ventricular drain and decompressive craniotomy if indicated. Now, there are certain red flags. The examiner may ask you anisocoria, hypertension, bradycardia, drop in GCS, ONST more than 6. Now, again, closing statement to get the gold medal. The patient has acute raised ICP with impending herniation. ONST comes to 6.6 millimeter. And I think this patient requires immediate herniation management in the form of hyperventilation, head elevation, osmotherapy, while urgently activating neurosurgical intervention. Don't immediately jump to that. I will be immediately calling the neurosurgeon. Neurosurgeon will not be be there that you are calling somebody from space would be just landing there, crash landing. No, this cannot happen. So you have to handle the immediate herniation package first, and then simultaneously you have to activate the neurosurgical consultation. Now coming to some of the CT thorax, yes, I think most of the things you know. 54-year-old, shortness of breath after long air travel, bilateral proximal acute pulmonary emboli. Okay, so again, the format remains same, but I am just like giving you the clue, the correct answer, so that we can buy some time. 70-year male, hypertension, sudden onset chest pain. What is happening? Can anybody tell me? Are you all with me? What is your GCS? Everyone? 15 out of 15? Okay, perfect. Yes, yes, yes. I want that maybe at least 20, 30 uh, correct answers. No, no aortic dissection. We don't want aortic dissection to any of our trainees or to me also. But yes, the examiner would be very happy. You can just describe in little bit in detailed way. It should not be again aortic dissection straightforward answer. But yes, again the classification, which type, and what would be the management protocol. So all these things. Yeah, I know you all know, but at the 10 p.m. I don't want to go into detail. Now, 56-year chronic alcoholic severe abdominal pain. You did the CT abdomen with contrast. What is happening? What is the CT finding? Hmm. Yes, perfect. Only necrot. I have given you clue. Chronic alcoholic, CT, contrast. Okay. Acute necrotizing pancreatitis. No, don't say pancreatitis. That is not something for like no, not for DrNB DM standard. Okay. Now, CT features of the acute pancreatitis, edematous pancreatitis, necrosis of pancreatic parenchyma. Again, I'm not going into detail. This is a very much like no, I can now expect that you will be start answering this question. Tense abdomen, fecal vomiting, high lactate. What is happening? Correct answer. Anyone? Okay, you all have answered. Large volume of portal venous gas, long length of non-enhancing small bowel with pneumatosis intestinalis, bowel ischemia or gangrene. Okay, so these are some of the CT finding. Poorly enhancing or non-enhancing bowel wall, pneumatosis intestinalis, small bowel feces sign, potomesenteric venous gas, arterial or venous thrombosis, free abdominal fluid or gas. 56-year female with ischemic stroke thrombolized within window period developed sudden onset abdominal pain. What is happening here? Yeah, perforation peritonitis, but there is clue that thrombolysis has been given, ischemic stroke. Now abdominal CT contrast showing large hematoma, and these are some of the contrast extravasation arrow in the abdomen. Okay, this is something contrast is now entering into this peritoneum, and there is extravasation happening. You all know it, but yes. Now coming to the neurology part, again I will be quick. 77-year-old woman, sudden onset left-sided weakness and numbness. She was last seen normal 4 hours before reaching to the hospital. CT brain has been done. What is your diagnosis? What is the immediate management? Right MCA infarction with midline shift, ABC, antiplatelet, statin, reperfusion therapy. Maybe I would go ahead with intravenous thrombolytics if there is no contraindication. 24-year RTA, loss of consciousness. Now, can you tell me what is the CT finding in this patient? Then only I will get to know that your all GCS is 15 out of 15. Exactly. So I am happy that you have maintained your like the GCS till 10:15 p.m. also. So it's a combination of subdural, epidural, and subarachnoid hemorrhage in open skull fracture. You can see, you can see, you can see, and you can see also open skull fracture. Okay. So this is very interesting city finding. Don't rush. Don't rush for the answer. You have seen STH, immediately you are answering STH. No, you can see also there is EDH on the other side. Okay. Now EDH looks like this. Acute on chronic STH looks like this. Now a 54-year hypertensive suddenly got collapsed in home. CT scan is shown below. What is your diagnosis? Management. What is happening? Yes. IVH. Very safe side. ICH with IVH. Some better answer. Left IC bleed. Thalamic bleed with IVH with EBD. Where is the EBD? Okay. Large hemorrhage in the left thalamus with interventricular extension. I will take care of the ABC, manital, head and elevation, neurosurgery consultation for EBD. A 45-year female presents with sudden onset headache since last 4 hours. Diagnosis, immediate management. What is happening? Yes. Yes. Very good. Perimesencephalic SH, neurosurgery call, nimodipine. Okay. Immediate management, you can start nimodipine. A 65-year-old man presented confusion, cortical blindness. His blood pressure in the ER was 232 by 160. What is your diagnosis and management? Press. Excellent. So all of your GCS suddenly became like 15 out of 15 when we have seen the neurologic cases only. So that is good correlation. No? Okay. Perfect. So it is the FLAIR MRI showing hyper intense lesion in bilateral parieto occipital area. So definitely it is press, and the management would be aggressive correction of the blood pressure. 34-year-old man presented with confusion, fever and agitation for 3 days. He was disoriented with weakness of his left arm. MRI brain shown below. What is your diagnosis? What is the definitive treatment? Confusion, fever, agitation for 3 days. Okay. So it is a T2 signal showing left temporal lobe and insular cortex enhancement. Most probably herpes encephalitis, and the treatment would be IV acyclovir. Now herpes simplex virus encephalitis, that is HSP1, classic temporal plus insular involvement. There would be behavioral changes plus agitation plus confusion. Fever and focal neurologic deficit would be there. Rapid progression would be happening. Now, key imaging hallmarks you must say in the examination: T2 flare into hyperintensity in the medial temporal lobe with insular cortex involvement. Possible hemorrhagic changes also can happen. There is no respect of the vascular territories that can also spread to the other vascular territories. Immediate or definitive treatment would be starting IV acyclovir immediately. The dose would be 10 milligram per kilogram IV every 8 hours. Start before CSF results come. That is the time critical zone. Continue for 14 to 21 days. You have to adjust for the renal function. Additional high yield points. It is a most common cause of fatal sporadic encephalitis. Delay in acyclovir significantly increases the mortality. You should be performing CF analysis plus HSV PCR and EG. In EG, you will get temporal periodic discharges, and you have to also simultaneously take care of the ICP range. So one line ASCII answer would be MRI shows left temporal and insular hyperintensity consistent with HSV encephalitis. You have to start immediate IV acyclovir.